the first session this afternoon will focus on the results that can be obtained from whole genome screening. And as I pointed out when I spoke this morning, the results that we obtain from this screening include results that may be of medical importance, but also may include results on things completely unrelated to what the patient's concern was, the reason that the doctor got the testing done. May also include results on things like non-paternity, on ethnic origin, on genes that may be associated with musicality or lack of that, or athletic prowess or lack of that, or other information. So there are so-called incidental findings of many sorts that can come from these. And the next thing we're going to do is to have a debate on these issues. Excuse me. We will ask each of the two speakers to introduce positions on this issue, on the resolution that clinicians should determine the nature and extent of whole genome testing results contained to patients. That is, we as clinicians should control this information. The two distinguished speakers are Dr. Sylvie Langlois and Dr. Michael Burgess. Dr. Langlois obtained her MD degree from the University of Sherbrooke. She did specialty training in pediatrics at McGill and in medical genetics at UBC. She's a clinical geneticist at Children's and Women's Hospital and a professor in the Department of Medical Genetics at UBC. She's medical director of the BC Prenatal Genetic Screening Program and has been in that position since the inception of that program. She also is currently chair of the Prenatal Diagnosis Committee of the Canadian College of Medical Geneticists and a member of the Genetics Committee of the Society of Obstetricians and Gynecologists of Canada. Dr. Michael Burgess, who is sitting next to her, is professor and chair in Biomedical Ethics at the W. Maurice Young Center for Applied Ethics, member of the Department of Medical Genetics at UBC, and currently is the principal of the College of Interdisciplinary Studies at UBC. Dr. Burgess is an ethicist. He combines ethical and social theory with social science methods related to policy in healthcare, health research, and biotechnology, with a particular interest in genetics. Without further ado, we will introduce this debate on the resolution. Clinicians should determine the nature and extent of whole genome testing results conveyed to patients. Each of the speakers will have 10 minutes, and we will strictly enforce that by the clock. Then we will open the floor to your participation, and I promise you'll have a chance to participate this time. And then we'll ask each of the speakers to summarize, and we may, depending on how it goes, vote to decide who wins at the end. Dr. Langlois is pro.
Thank you very much, Jan. Yeah. So I will talk in favor of physicians essentially determining which results of genomic testing should be provided to patients. I think I was dragged into this debate without knowledge of who I was debating. Because who would possibly debate an ethicist? It's almost like debating a lawyer. But I will do my very best to prevent arguments.
Sorry,
what are you
it doesn't
doing?
seem to be
This isn't counting. Not that I want to admit defeat, but because I am debating against Mike, this may be where I end up. But I hope to get your participations at the end in support of my side. So I wasn't sure how to approach this debate. I don't think I yet have the white hair or the baldness to take an evidence-based approach to this. So I thought I would go for evidence-based medicine, how we base clinical decision based on clinical studies and research. However, there is very little evidence about how we should deal with results of this new technology for the benefit of our patients. Having said that, I do think that genomic testing, what we're talking about today, is using new genomic tools, so let's say whole genome sequencing, in the context of clinical medicine, in the context of a patient who comes to us with a clinical problem that we think likely has a genetic etiology. So really, it's still just dealing with patients in a clinical problem. So I think that our clinical approach to this should be very much based on the experience that we have and the principles that have guided our practice up till now. It's not because it's genomic technology that all the principles of how we've done medicine before should be sort of, disregarded. So my feeling is that as physicians, we essentially have a physician-patient relationship, and in that context should continue to be the ones who provide and decide as a group of physicians what is best for our patients and in that context, what kind of results we should provide to a patient. I don't see our patients as our clients coming to us as consumers buying their genome. So I think our number one principle should be primum non nocere. Thought it would sound even more important if I used a little bit of Latin here. So essentially, we should first do no harm. And I thought this was an interesting thing I took off the web. Do no harm, but it also, we need to know the harm that we may do. And that's why I think we need to be very cautious when approaching genomic medicine, genomic testing. So I contend that physicians should provide results of testing that directly relate to the clinical problem that we are facing with our patients. And yes, we should provide genomic incidental findings that are predictive of high-risk disease, because we do that already. When we do a test and we find something else that's just as clinically relevant, we actually deal with both things. But that these variants of unknown significance, the traits that we uncover that may be predictive of a slight increased risk, or even that are recessive traits, should not be at this point shared with patients. And this is a nice cartoon. Maybe you'll start feeling better if you stop reading WebMD, and I've added, and the result of your genomic test. I think that there is great harm to be done if we start embarking in sort of looking at the entire genome and everything that it shows. But before I tell you this, this is actually March 2011, so it's entirely current. It is the nice story of one case that saw a bunch of physicians. They were baffled. This isn't a family with multiply affected kids. This is not a condition where 300 patients were known and collected by a researcher. This is one child who presented very early on with refractory inflammatory bowel disease. And after lots of investigations, physicians decided that this had to be an immune deficiency. And because they couldn't define it, they actually did whole genome sequencing, and they did find the immune deficiency. But I want to point out to you that in addition to finding the sort of immune deficiency, they found that this particular child had 1,400 novel protein coding changes. So there were 15,000 found, but a lot of those were already described in genome databases, and so they felt, okay, won't worry about those, but there's 1,400 that were new. And a lot of those, when we say non-synonymous, means that the change changed a protein. And so these are all in genes. These are, 879 of them were protein changes. So are we really going to release to patients and families this catalog of hundreds and hundreds of changes when we don't know their significance. And this is very similar to what Jen has already presented, that in fact, Lupsky also had his genome sequenced to find disease in the family. And there were lots of non-synonymous changes. A lot of these were already known, but what the point of this slide is that there were 159 that were actually disease or trait related. So increased susceptibility for this, decreased susceptibility for that, 21 recessive trait. We're all carriers of recessive trait. Are we going to start worrying about the 21 that we carry? Like, do we need to sort of give this information to patients? And I think that we went from not being able to go far enough in genetics. I've been in practice for a long time where we couldn't offer anything to patients in terms of making diagnosis and giving treatment. And I'm worried that now we're being pushed by consumers to go too far, going from not enough to too much. I think that first do no harm. If we want to provide testing to patients, like providing a service, they should come to us and make an informed decision, informed consent. How can we possibly reach informed consent if we're consenting them to not knowing what we're going to find? So I think that there's a great problem there. We also need to provide results that are meaningful. Is it meaningful to give them a list of 800 changes? What are they going to do with this information? We want to use these tools because we think we're going to find diagnosis. It's going to maximize our ability to make a diagnosis. But we need to be careful that we minimize false positive. I think that if I give them a long list of traits, I'm actually giving them a lot of false positive. That's not what they came for, and now they're going to be anxious about these positives. Potentially, also, if I don't find the cause of their problem, but I give them a long list of things that I think is insignificant, they may not perceive that to be insignificant. They may even think that I found the cause when I haven't found the cause. The other concern is that the reality is a lot of these tools are being used in minors, and we as geneticists have developed guidelines as to not doing carrier testing in minors, not doing predictive testing in minors, because we're essentially taking away from them the ability to choose as adults as to whether or not they want this. And if we start revealing all of this when they're 2 and they're being investigated for their intractable sort of, Crohn's disease, we're actually predicting things for adult that they may not want to know as adults. So I think we should minimize negative impact by limiting what we give as results to diagnosing disease or high-risk condition. So by that I mean, yes, we may have cases where the 7-year-old that's being found to have developmental disability investigated for this is found to have a large deletion, and the deletion covers and deletes the gene for breast and ovarian cancer. Yes, we may find more than we were looking for. We will have to deal with that because that's a high risk. But that's not to say that we should give them a catalog of disease and trait associations for which we really have very little data to say exactly what the magnitude of the risk is. It has the potential to raise anxiety and the potential for false reassurance. I don't think patients are there to find out that, they're predisposed to suing doctors. So the other thing is, as I said, these variants of unknown significance, I think that they have the potential to be misunderstood by patients. And there's an interesting presentation at the American College of Medical Geneticists meeting this year where this group that had done microarray testing on a large number of patients, and microarray even detects less variants than this whole genome sequencing, they actually revisited all these people that they had given results to and asked them 3 questions. Okay, the first one was, we found an abnormality in your child. Did you think that it was the major explanation, probably unrelated? Was it uncertain? So, people had to choose because these results included both pathogenic and others of unknown significance. And then they had this very sort of, the chromosome finding is the cause of my child's problem, and the last question was, I'm confident that we found the cause of my child's problem. And essentially, the geneticists scored and the patients scored. And there was very little concordance, okay? So between geneticists and genetic counselors, they had perceived the same information. But between the physician and the patient, half the time there was a discordance. That means that when we provide complex results of unknown significance to patients, they can easily be misunderstood. So essentially, I think that whole exome sequencing result as a catalog of disease and trait association has the potential of not improving healthcare, but has the potential to significantly increase the cost of healthcare, because all the anxiety that it will create will be associated with more testing, and these tests do come with their own risk, and therefore we should limit results to what the initial problem
Thank you,
was.
Dr. Langlois. Opposition, Dr. Burgess.
So let me tell you what I'm going to tell you, then tell you, and then tell you again. I want to argue that, and I'm going to do what's really unfair in ethics, and that's I'm going to take the arguments that Dr. Langlois has made and enlarge the context so that I'm going to argue from a very different environment. And I want to argue that the technology, particularly genome scanning and genome sequencing, provides benefits and risks that change relationships and responsibilities, and attempts to apply the old rules about physician-patient relationships is problematic. That there's a paternalism of the clinical standard of care that is justified in many cases, but is unjustified in this case, and that uneven access to genome sequencing is a source of injustice, and restrictions to access are not justified. I'll go through a series of web captures, actually, to suggest what the larger context is. So the National Human Genome Research Institute provides what we think of as pretty good, screened, reliable information about genome scanning, and suggests that genome sequencing will be at the rate of about $1,000 in the next 3 to 5 years. That suggests then that the sequencing will replace many genetic tests as the way that we begin to provide clinical care. So that when we start to think about genetic testing and genome sequencing, it's important to notice some particular differences. Incidental findings are often what we're trying to manage when we talk about genetic testing, but in genome sequencing, often what's going to be happening is the sequencing itself will be the purpose. It's the full information that many people will be after. When genetic tests, when someone asks about information, one of the key questions is whether the information is there without additional cost, or do you have to do another genetic test? It's there. It's a one-time cost with sequencing. We talk about social risks to individuals as a result of knowing genetic information. For example, insurance, access to insurance, and the cost of insurance. But in many of these cases, the risks are very widespread and diffuse, and it's unclear that we protect the individual by simply metering out how much information they get. We talk about familial implications of genetic testing, but genome sequencing are highly variable in terms of whether it's relevant to family members and exactly what that relevance is. And when we're talking about research tests in terms of genetics and whether we can use them in clinical settings, the sequencing quality is likely to be similar whether in research or clinical settings in the near future. So that I want to argue that I have the fast speak gene, that's why I can do this in 10 minutes. The clinical standard of practice we usually refer to is a way of doing what Dr. Langlois said earlier, which is avoiding harm, but at least making sure the harm we do is justified. Clinical standard of practice suggests that we always need to make sure that the harm inevitably conducted, say by a surgery, say by life-prolonging treatment, doesn't lead to consequences that are more harmful than the ones we caused by doing the treatment. But when we get into managing information and testing on this clinical standard of care, the benefits sometimes of information is very difficult to calibrate, and the harms of getting information are largely dependent on the social context. So that becomes very important. If we manage information on a clinical model, on the standard of practice, of course we're going to argue that the information must have a clinical use. And since the information is what we're looking at, how people respond to it and what the social environment does, social and psychological risk ends up being the kinds of things we consider. But as we've seen in many of the early worries about genetic testing, for example, with Huntington's disease, it's really difficult to calibrate those risks. And then we enhance that. And these are not really paternalist arguments, but there's third party and duty to warn. The other kinds of responsibilities that health practitioners often have is to make sure that the risks to others as a result of my getting information, to, for example, my siblings and my parents, or that if they have there's a chance of them benefiting, we deal with duty to warn. All of those are the kind of responsibilities we deal with in clinical settings, but that's not what we're talking about. You can go online now with patients like me, this is a for-profit website, identify your clinical concern or your disease, and begin to social network across diseases. You can go online and decode me. You can begin to provide samples to companies who are online, operating in many cases for profit, and they will provide you with genome sequences. And the people who've really got this nailed is 23andMe. And I have what was to show an alarming number of captures from this. We can come back to these. But 23andMe will directly test you and provide you with information about things such as your risk for type 2 diabetes, who are your cousins, connect to them, what's your risk, age-related macular degeneration, what countries might your ancestors have lived in, do you have a sensitivity to certain blood pressure medications, and of course pharmacogenomics. The long-hanging fruit here are the ability to be able to sort out populations so those most at risk for adverse events are not given those drugs and others can benefit from it. So again, a real sales point for people wanting access to genome sequences. And so what 23andMe promises is they will give you information about whether you're about to pass on 24 inheritable conditions. Stand closer to the mic. I'll stand closer. I'm almost through, I think. So what 23andMe claims is that they will provide to you results to a growing list that's currently at 193 diseases and conditions. That they will provide revolutionary ancestry tools to figure out who your ancestors was, and they'll provide you with an ongoing service of updating you in terms of what the relevance is of your sequence data. So the problem here is not one of paternalism. The problem here is one of justice. Some patients will receive genome sequencing as part of their care because it's part of what they need to do, and those are the tests will provide. Others will purchase it. Others will neither have the test through the healthcare system, nor will they choose to spend the money or be able to afford even a $1,000 genome. And the result will be that those who have genome sequencing information, probably carrying it around in something like what's familiar as a jump drive, will come in and demand more healthcare advice. They will come in and expect explanations. They will come in and probably get faster treatment. As many of the testimonies on these web pages suggest, people with this information are able to get physicians to respond more quickly when they come in with a familial-related illness and a sequence that suggests that they might be at increased risk. And they will probably be perceived as more responsible, because we live in a risk management society that sees people as responsible for managing their own health. And if you get a sequence, genome sequence, and you begin to manage your own health more assertively, you're more likely to be seen as responsible, and that too, we're pretty sure, influences your access to healthcare services. So in the near future, access to genome sequencing tests will provide benefits that will not be evenly distributed. The healthcare system and online information must provide good online sources, and what we're going to be faced with is actually a healthcare system that's going to have to deal with these very uneven sources of information and interpretations. And in conclusion then, the access to information is that, first of all, paternalism in this case is not justified. The information is an advantage, the risks are dilute and widespread, and the real challenge is how to provide reliable information so that people who are getting this the genome sequencing done have a way of interpreting it. So the conclusion really is that access to the full genome sequence information will be required to fairly distribute the benefits of this new technology. Thank you.
Thank you very much, Michael. Let's see if we can. Okay. So we will now open the floor to questions to either one of our, or both of our discussants. I would ask you to come to the microphone so that we can all hear you. And people who are on the webcast, if you will click on the balloon that's in the lower left, is that correct? Lower right. We will get your message, and Shellen will relay it. So do we have questions, comments? Yes?
I'm just curious as to what the legality is in terms of disclosing this information at this point. Like if you run a full sequence, are you legally, as a physician, obligated to disclose this information? Can you get sued if you don't? That's my question.
It should be on.
Yeah. Essentially, there's already some precedent where you can run a test and choose to visualize just part of the information. So with, for example, tandem mass spec that's used for newborn screening and for the diagnosis of biochemical disorders, they essentially choose to focus on the peaks where there are some specific diseases. So one of the arguments to deal with the issue for genomic sequencing is to say that, in fact, instead of looking at the whole genome, we will sequence all the genes or all the exons, but we would essentially tailor the analysis to the group of genes that relate to the pathology so as to avoid essentially seeing all these variants. So that would be one approach. And in fact, there's a paper that was written by an ethicist whose point of view was that, this was one of my counter-arguments, that we should bundle genetic testing rather than bungle genomic testing. So, you know, it may be, I think my perspective is that, you know, there's going to be a learning curve and we should take small steps so that we do it properly. And one way would be to do the whole sequence, but to focus on segments of the genome that are directly related to the problem that presents to you. And I think in that context, we would probably be protected from a legal point of view.
Which we would expect because we're maintaining a conservative standard of practice and not taking into consideration the fact that this is a rapidly evolving technology that we cannot control. And so that it preserves the physician-patient relationship and the paternalism inherent into it, which is a very good thing for all sorts of purposes, in a way that simply refuses to acknowledge that this information is widely available and being misinterpreted. So the alternative legal interpretation is if it's on the record, the patient has a right to it, as opposed to as long as you're acting according to the standard of care of your peers, you're legally protected.
Yes.
Public health policy often suggests certain things that are for the general population's benefit. Yet in family practice, where I come from, we tend to look at individual cases and try and make some decisions that might be pertinent to that individual. So where does individual variation come into play when we start to think about what information should be available to whom, when, and where?
I think this is exactly what I would argue, is that what we most need is personalized medicine in the sense of family physicians and others who are well equipped to make the very specific interpretations of context and risk and interpretations of family history in light of the genome sequence, instead of leaving people to go online to find sort of generalized data. So I think it's absolutely crucial that there be a clear role for family physicians and geneticists in this.
Sylvie?
I'm not sure if you're asking whether or not the patient, the role of the family physician should be to determine if or have the patient determine what they want, as opposed to us coming with guidelines that suggest what should be done.
Well, I'm really thinking that in theory, it may be wonderful that everybody should have access to all the information and let them decide what to do with it. Or do we have to recognize that people are unique and therefore sometimes they can't all deal with all the information they've given, and therefore there is a role for some of us to filter through the information and present it in a way that might be useful. So I was just thinking the model in public health or population health, we have guidelines which are absolutely perfectly excellent guidelines, and we could debate those guidelines, yet in a different setting we have a different set of parameters, and we have to debate those parameters in that setting. And so that's really what I was wondering in our debate, as to which setting are we debating this in, and is there a need to consider that as one of the, our discussion points.
Well, I would take the side that as healthcare providers, we need guidelines, and that experts from different fields should get together to develop the guidelines that would essentially set the new mark as to what kind of information we should share with patients rather than sort of individualize at the patient's request. There will always be a market. There's obviously money to be made if 23andMe is investing, and so I don't deny the fact that some patients will buy the service, the same way there are some services in medicine that are purchased but not felt to be sort of justified. I mean, we don't do routine total body MRI every year on everybody, and there are people who go and purchase the service. So I think that we should have policies and guidelines for the use of this technology, for sharing of results, for which results we share, as opposed to being market-driven.
Dr. Diaz.
So I have two questions, one that relates more to personal health and another that relates more to public health. So with regards to the personal health question, and taking into account what Dr. Langlois showed at the beginning, the do no harm and do no harm. So currently the information that we have regarding several genetic variants, for example for cardiovascular disease or for dementia, they're all, most of them, or I'd say very few, are not predisposition to disease. So it's very likely that we have many protective genetic variants that just because of the bias of the way we perform our research, that we actually don't know what those protective variants are. So the information that we're giving our patients is going to be biased towards that a deleterious effect, most certainly. The question is that they probably do have protective effects that we just don't know about. And so how are we going to balance that information that we are giving them, saying that you have an increased risk for cardiovascular disease, but the truth is we really don't understand all the rest of your genome, and maybe you have a protective effect. So are we giving them information, disinformation, misinformation? What kind of information are we giving them? The other question that I have is with regards to public health. So hoping that we will reach a point where we do understand all these variants that we're looking at, do public health care providers, the provincial government, is it warranted that they should have access to this information in order to be able to guide public health care? Let's say that in BC we have a population that has a huge increased risk for dementia. That's certainly going to direct provincial health care towards increased care for patients with dementia or cardiovascular disease. So in terms of healthcare benefit and healthcare costs, we can actually work on a public health basis as well. And so who should have access to that information, and what's the best timing for them to have access to that information?
I agree with you for the personal health, and I think Tamara this morning talked about the fact that we're very focused when we provide information on the negative rather than the positive, and because that's what the research has been based on, I think that if we start giving information at the moment based on what's in the database, it will be highly based on disease rather than protection. And I would argue that everything so far that is available is no better than a good family history. And I think that there's a whole lot of money being spent to look at susceptibility, but I think if you do your family history, you've got the same information, and perhaps you should be happy that you've got grandparents that are in their 90s, and so that kind of family history is useful too. From a public health point of view, as much as I'm concerned about giving information on the individual because I think it may be misused and misinterpreted, I would actually be much more open to anonymized data being given from for a public health point of view to plan health care, as long as the data that we use is based on good evidence and good studies. But once we have good evidence, I don't see the harm of that data being used from a public health perspective.
Back to the personal level, I mean, there's a paternal kind of approach that I really want my physician to have. I want my physician to make decisions about what she thinks is in my best care and provide specific advice and not just give me generalized information. But one of my worst experiences in the last decade has been an accountant who protected me from information. I don't want any professional standing between me and what information I think is relevant to my life. So when it comes down to healthcare, yes, I want paternalism. When it comes down to access for information, I do not want anyone standing between me and deciding what's relevant and what's not. On the issue of public health, one of the good reasons to be sure that our healthcare system provides genome-wide screening is so that we can, in fact, establish databases that allow us to do the kind of population health planning that's being suggested, as opposed to having it residing in a bunch of private biobanks that we're not able to access.
Next question, please.
So I have a couple of questions for Dr. Burgess. In one of your concluding slides, you said that basically your opinion is that every patient should have access to the whole sequence of their genome. I was wondering if, so for one, if you could comment on the format of that information that is available to the patient. Would you want it to be electronic or paper? And do you want, can you comment on the sort of difficulty of reading 6 billion base pairs of DNA and extracting some sort of meaning out of it for the layperson? So that's my first question. And then my second question is, do you think disclosure of whole genome information to patients should be active, i.e. the clinician goes to the patient and says, here is the information, do whatever you want with it, or passive, where the situation is the patient can request the information if they want it, but the clinician isn't actively giving it to them? So if you could address both of those, I would be very grateful. Thank you.
Quickly, the format of the material will have to be electronic because no one's going to be able, including most of us in this room, could sit down and manually read the sequence data. It's going to have to be a search function where people are matching against the sequence. And so it will have to be electronically accessible and provided for search engines to be able to search. So that's got to be the format. I don't think you should ever provide a patient something they don't ask for or you don't think they need. So you should always be waiting for either a request. It's a little bit like telling a child about their risk for genetic disease. You wait until they're at a point where they're naturally curious for it. And patients may well, for lots of reasons, not want certain kinds of information. You shouldn't take the responsibility to make sure they get information they don't want, but you should be able to be responsive in cases where they request it with a reasonable response.
We don't currently have a situation here where that information is necessarily going to access or limit somebody's access to health care or health insurance, but it certainly can limit their access to other types of insurance and certainly entry to other careers. And so I'm curious as to how you see that you keep this particular genie in the bottle. I mean, you have someone who has had a genome scan and then goes to revise their life insurance policy, and the life insurance company says, have you had a genome scan? How do you keep the genie in the bottle? And you may choose to use it for certain information, but can you protect individuals from discrimination in that context where someone else may, knowing that all that information is there, choose to look at it for things than the purpose for which it was otherwise originally collected?
So I should be, I won't say perfectly clear, I just did, but I should be clear that I'm not saying it's a good thing the sequencing information is widely available. I'm just saying it is. And the new environment we're in is one where we have to manage the benefits and risks of a wide access to genome sequencing. So when we come to issues of individuals at risk, by individualizing the problem and saying, how do we protect that individual? Well, let's do it by making sure they know what the risks are of having this piece of information. We don't change any of the systems. We load the responsibility onto the physician and onto the patient and onto the genetic counselors to make sure they've considered that and then not minimize the risk, but decide whether or not to take it. What we really need is a much more systematic approach to that, and wide accessibility to genome sequencing data will be the motive for us to make sure that we have a fair approach to things like life insurance and job assessments.
Yeah, hi. So I don't really have so much a question for both of you, so much as I'd like to solicit your opinion. This is all kind of aimed pretty forward thinking, I think, despite the dramatically falling costs of sequencing. I don't know that everyone in here is going to have their genome sequenced in the next 5 years. But in the next 5 years, what is going to happen is laboratories, both here and elsewhere, are going to start seeing a lot a lot of work coming from the types of technologies that already exist there, so the 23andMe and the stuff. And as this these consumer technologies and genome sequencing, et cetera, take off, those kind of things are going to come more and more to laboratories. I'd like to know how you guys visualize the role of the laboratory in this. Or is the laboratory an additional gatekeeper, as you guys have been talking about, sort of the physician, either screening, blacking things out, not blacking things out, telling everything, telling nothing. How do you see the role of the laboratory changing, over the short term in the next few years to deal with these kinds of things as they take off?
Thanks. Sounds like I paid you to ask the question, because that was in the half of the talk I didn't get through. But I actually, when I talk about physicians, I don't mean, I'm not limiting this to clinicians in their practice. I really think of us physicians and lab scientists as together trying to decide what needs to be revealed. And my feeling about that is that, in fact, limiting results will allow this technology to be implemented. Because if we try to go for imposing on laboratories the need to report 1,500 variants and their significance, and keeping up with what is developed, who's going to revisit that report every time there's something new, we will essentially never see this technology being transferred from the research lab to the service lab. My analogy to that would be, if we decades ago wanted the self-parking car that Ford's come up, we'd still be walking. We accepted, a model that did the basics because it provided transportation. And so I think that we need to have these discussions, we need to have these debates, but we also have to be practical. And I think that we need this technology in clinical laboratories within the next 5 years. And to do that, we have to be realistic as to what our expectations are.
So quickly, I think it's very important. We think about laboratories as moral agents. They bear the burden of knowing what kind of information they pass on, and it's really, I think, absolutely crucial we look at both standards and appropriate testing regimes. So it is going to be pretty key that we involve laboratories and the full range of technical specialties involved in sequencing to make sure that the standards are things that everyone can live with.
Thanks.
Thank you. Last question, Dr. Tucker.
Thanks. My question has to do with many of the variants that have been looked at for increased disease association have to do with an increased risk in a white population. So when we go to whole genome sequencing and we are sequencing a genome that's not of a person who's Caucasian, and we find that increased disease variant, how do we give the information to the patient as to whether that's an increased risk for that population when it hasn't actually been researched in that population? If it's personal medicine, it has to take into account the ethnicity of the person, because many of these susceptibility genes are restricted to certain ethnic groups. So how do you handle that?
Oh, I completely agree with you, and I think it just is a good example of the complexity of the state we're in, and the fact that we don't have the data for these results to be interpreted properly.
So this is why I emphasize that the key here is reliable information. We absolutely need to find out, because this market's going ahead whether we participate in it or not. We need to find ways of getting reliable information so that people can make those, or be supported in making those kind of interpretations. It's absolutely crucial. If they don't come to the healthcare system to get it, I don't know where else they're going to go. I guess we should be using things like the National Genome Research Center websites to provide more reliable information. There are other sources too online.
So then a movement away from the public's, moving towards a public system rather than a private system that's going to benefit from adding more and more tests that haven't actually been validated as well. Because the public system has it, or the public system can't support it currently to be able to validate each of these tests or to run each of these tests, where the private sector is actually going to benefit by adding these susceptibility genes that actually have no peer-reviewed evidence towards it.
That's right.
Okay. Dr. Burgess, can we give you 3 minutes to summarize, please? Who would you like to come up with?
So I'm actually going to break frame now and suggest that we need to consider carefully both the inevitability of having the wider context where genome sequencing is widely available, for profit, and unregulated, and there's no testing, and what is the responsibility of health professionals to figure out patients and help society figure out how to deal with those issues. And so I think we do need to come back to the issue of what's the appropriate exercise of professional discretion, what's the appropriate exercise of when, just because someone else can get something in the market, doesn't follow from that there's an obligation to provide it within the healthcare system. So I think it really is important that we think about this not only in terms of how do we become part of a commodity, a market commodity that is promoted online for profit and for a variety of other reasons, but also asking what is the appropriate role of the healthcare system? Where are the places? It doesn't mean that we should now provide information that's not relevant to healthcare, that people can get it elsewhere. Our challenge is the fact that people get it, they can come in and we'll be responsive to that. If someone comes in with an early onset breast cancer and they have no family history, but they have a relevant mutation, they're going to have attention paid to them that they may not have attention paid if they don't have that sequence and they don't have a family history. So it will make a difference to healthcare, and it calls for some real engagement on our part, not just in deciding what we will and won't do, but how do we help the healthcare system respond to some very challenging information availability and market-driven use of that information in the broader society.
Thank you, Mike. Dr. Langlois?
Well, I think I just want to finish by saying this technology is coming. It is going to affect all our practices before we retire, but we do have some time and we should take advantage of that time to sit down with all kinds of healthcare providers to come to some consensus at what would be best for our patients so that we are ready when it is available in clinical practice.
Thank you, Dr. Langlois. So let me now ask you, the audience here, who won? The question again was that clinicians should determine the nature and extent of whole genome testing results conveyed to patients. How many of you agree with that along with Dr. Langlois? Hands, please. And the counter-argument, how many are opposed to that along with Dr. Burgess? I think the agrees have it. Thank you both.